In this video, we're going to talk about meconium aspiration syndrome. Meconium aspiration syndrome is the aspiration of stained amniotic fluid, which can occur before, during, or immediately after birth. Meconium is the first intestinal discharge from newborn. Water is a major liquid constituent comprising around 90% of meconium. The remaining 10% of ingredients consists of solid constituents, primarily intestinal secretions, mucosal cells, and the solid element of swallowed amniotic fluid such as proteins and lipids. Overall, compared to stool, meconium is sterile. Meconium aspiration syndrome is defined as respiratory distress in newborn infant born through meconium-stained amniotic fluid, whose respiratory symptoms can't be otherwise explained. They are born through meconium-stained amniotic fluid. They might be meconium-stained, and we can explain the respiratory symptoms only by meconium aspiration syndrome. There is no other explanation than meconium aspiration syndrome for the respiratory symptoms. The risk of meconium aspiration is greatest in post-term infantis and small for gestational age infantis. Factors that promote the passage of meconium in utero include the following: placental insufficiency, maternal hypertension, preeclampsia, oligohydramnios, fetal hypoxia, maternal infection, including chorioamnionitis, and drugs. Normally, in utero, infants are not expected to pass meconium, but those factors cause the neonate to pass the meconium in utero. In utero, meconium passage results from neural stimulation of a maturing GI tract, usually due to fetal hypoxic stress. Aspiration of meconium-stained amniotic fluid may occur if the fetus is in the distress, leading to a gasping breathing pattern, or it might occur after delivery when the baby starts to breathe. This aspiration induces hypoxia via four major pulmonary effects. Those are airway obstruction, which can be partial or complete, surfactant dysfunction, surfactant washout, chemical pneumonitis, and even by causing pulmonary hypertension. So, to summarize it in this form, in post-late or post-term babies, due to physiologic meconium passage, and in others due to fetal compromise, meconium passes. When meconium passes, meconium becomes stained in amniotic fluid. This meconium-stained amniotic fluid is either aspirated after delivery while the baby breathes, or it can be aspirated while in utero when the baby gasps. Then this meconium aspiration causes peripheral airway obstruction, which can be complete or partial, or it might cause proximal airway obstruction that causes air trapping. It can cause acidosis, hypoxia, hypercapnia, and also inflammatory and chemical pneumonitis, and also remodeling of pulmonary vasculature, which causes persistent pulmonary hypertension. History of meconium-stained amniotic fluid are there. Baby's nails will be stained with meconium after 6 hours of exposure to meconium, and the umbilicus will be stained with meconium after 12 hours of exposure. Birth depression occurs in 20 to 30% of infantis, and most of the time affected infants are frequently small for gestational age or post-term. Infantis who develop meconium aspiration syndrome exhibit signs of respiratory distress immediately after birth. Those includes nasal flaring, intercostal subcostal retraction, chest drawing, tachypnea, chest bulging or balear chest, cyanosis, index expiratory grunting, and when you auscultate their chest, rales and rhonchi can be heard. Severity of meconium aspiration syndrome was graded on the basis of requirement of respiratory support as mild, moderate, and severe. We call it mild meconium aspiration syndrome if they require less than 40% of oxygen for less than 48 hours. We call it meconium aspiration syndrome as moderate if they require more than 40% oxygen for more than 48 hours. And we call it severe if they require assisted ventilation for more than 48 hours or if they have complications such as air leak and persistent pulmonary hypertension. We also grade based on chest X-ray. Grade 1 meconium aspiration syndrome based on chest X-ray. On chest X-ray in this case, it shows streaky linear densities, which looks like transient tachypnea of the newborn. Grade 2 is when lungs typically appear hyperinflated with flattening of the diaphragm and diffuse patchy densities with areas of expansion. Grade 3 is the severest form. In this case, lungs develop an appearance of homogeneous density. It looks like a baby with respiratory distress syndrome or hyaline membrane disease. The diagnosis of meconium aspiration syndrome is made by the following clinical based findings. Those are: there is evidence of meconium-stained amniotic fluid or meconium-stained baby, and respiratory distress at birth or shortly after birth, and characteristic X-ray features. Differential diagnoses include transient tachypnea of the newborn, delayed transition from fetal circulation, persistent pulmonary hypertension of newborn, sepsis, or pneumonia. Transient tachypnea of the newborn is a disease of late preterm babies, whereas meconium aspiration is a disease of post-term and is more for gestational age babies. Regarding prevention, because of the potential for poor outcome, the best approach for managing meconium aspiration syndrome is prevention. Intrapartum prevention. Intrapartum care to reduce incidence of mass include prevention of fetal hypoxia, that is through following the labor appropriately with partograph, which is very important contributor to the pathogenesis of meconium aspiration syndrome, and also prevention of post-maturity. If a baby is more than 42 weeks, it should be terminated. American Heart Association guidelines continue to recommend tracheal sanctioning of residual meconium to be performed in non-vigorous or depressed infants. In those who have absent or depressed respiration, decreased muscle tone or hypotonia, or heart rate less than 100 beats per minute with meconium-stained amniotic fluid. For vigorous babies, no need of sanctioning the trachea. Just tracheal sanctioning is recommended for non-vigorous or depressed infants. When we came to management, the general approach to care include maintenance of adequate oxygenation and ventilation, minimal handling of the infant to avoid agitation, care in a neutral thermal environment, empirical antibiotic therapy till we rule out sepsis or pneumonia by workup, cessation of any metabolic abnormality including hypoglycemia, acidosis with increased oxygen consumption, maintenance of adequate blood pressure and perfusion. Respiratory management is focused on maintaining optimal oxygenation and ventilation, especially as hypoxemia, acidosis, and hypercapnia may increase pulmonary vascular resistance and contribute to the development of persistent pulmonary hypertension. So optimal oxygenation and ventilation is necessary. Hyperventilation, respiratory alkalosis, and air trapping should be avoided. Supplemental oxygen therapy is usually adequate in patients with mild to moderate meconium aspiration syndrome. In patients with severe disease, intervention may include mechanical ventilation, high-frequency oscillation, even giving surfactant, because meconium aspiration causes surfactant inactivation and the surfactant washout. Giving surfactant might be important, and also inhaled nitric oxide therapy might be needed. In patients with respiratory failure who have failed to respond to other intervention, ECMO might be a life-saving intervention. Surfactant may reduce the severity of respiratory disease and reduce the need for ECMO in mechanically ventilated infants. Inhaled nitric oxide is a selective pulmonary vasodilator that might improve oxygenation in patients with associated persistent pulmonary hypertension. The other issue is antibiotics. Even if meconium is sterile, the mucopolysaccharide component of the meconium is a good culture media for bacteria, so it might predispose for bacterial pneumonia. So because of the risk of infection and the difficulty of distinguishing between meconium aspiration and the bacterial pneumonia, begin broad-spectrum antibiotics while awaiting the result of blood culture. Maintaining sufficient intravascular volume is important. Then, in addition, maintaining hemoglobin concentration above 50 gram or hematocrit above 40 is also important. Sometimes even vasopressor support is needed to maintain adequate blood pressure. When we came to outcome, the overall outcome of meconium aspiration syndrome have improved with advances in neonatal care. Pulmonary morbidity include persistent cough, chronic cough, reactive airway disease that might appear to be common in patients who had meconium aspiration syndrome. About 20% have significant neurodevelopmental impairment. However, birth depression occurs in 20 to 30% of patients with meconium aspiration, and it is likely intrauterine asphyxia that are the major underlying pathologic factors resulting in poor neurodevelopmental outcome. The long-term outcome depends on the level of asphyxia. Thank you for watching, and don't forget to like and subscribe.